Hi, my name is Veena Calambur. I'm a second-year PhD student at Drexel University. I'm excited to present our paper entitled A Case for Little English in Nurse Notes from the Telehealth Intervention Program for Seniors, Implications for Future Design and Research. I'll be presenting this work on behalf of my co-authors, DongWhan, Dr. Melody Schiaffino, Dr. Zhang, and Dr. Jina Huh-Yoo. The focus of our study was the Telehealth Intervention Program for Seniors, or TIPS. TIPS is a community telehealth program that offers telehealth services, including remote vital sign monitoring and wraparound services education for seniors. These services are offered in community settings where seniors often congregate, such as retirement homes or senior centers. TIPS has served over 2,000 participants over the past 10 years since 2014 across 25 sites in 5 states in the northeastern United States. So, how does TIPS work? During their visits, participants have their vital signs, so their blood pressure, their pulse oximetry, and their weight, measured by the on-site trained technical assistants. Participants also fill out a questionnaire about changes in their medication, mood, or falls and hospitalizations. TIPS employs remote nurses who monitor this vital sign and questionnaire data in their web portal. If any readings trigger an alert, it gets assigned to a nurse as an alert task. Nurses can then determine whether they want to follow up with participants to complete an alert response protocol. This comprises reviewing the participant's vital sign history, calling participants by phone to conduct a medical assessment, and providing care instructions. Nurses then document their response to the alert in a nurse note. Previous research done on TIPS has found that the program has been beneficial to providing care to underserved individuals and has provided additional benefits of community and socialization. These exemplify the community and health aspects of community health. TIPS has successfully recruited and retrained female participants with limited English proficiency, or LEP. This is compelling as generally patients with limited English proficiency in the United States experience structural barriers to accessing and utilizing healthcare. One of the major contributing factors is challenges related to health communication and coordination due to lack of professional language translators. Often there's an over-reliance on LEP informal family caregivers to do this work, and caregivers often report higher levels of stress and caregiver burden. Regarding the social and community aspects of TIPS, participants have reported one of the benefits of the program was opportunities for socialization among other participants as well as the TIPS staff. Previous CHI research has found that community health workers often take on social and communication responsibilities. In particular, they function as infomediaries, or individuals who both gather and communicate information and provide decision support. Our aim was to really explore the intersection of these dynamics in TIPS, understanding how TIPS nurses gather information and communicate specifically with LEP participants and/or their caregivers. So, we set out to address the following research questions. What challenges do nurses encounter in information gathering and instruction delivery with LEP participants and TIPS? What workarounds do these nurses perform to address these challenges? And what is the scale of observed challenges and workarounds among LEP participants compared to their English-speaking counterparts? I'll give a brief snapshot of the data and the participants we studied in our analysis. TIPS provided us 5 years of program data from 2014 to 2019. This included demographics, vital sign and alert history, and the nurse notes that were responses to the alerts. Because of this was our focus to study nurse notes, we only included participants that had at least one alert and a corresponding response from a nurse in their program history, and participants who reported their language preference in their demographic data. As a result, 1,208 participants with 23,975 nurse notes were included in our analysis. Participants were predominantly over 60 years old, female, and had a history of chronic conditions. And 23% of participants were limited English proficient, or LEP, while 77% were English proficient. We conducted a 2-part mixed method study. The first component was a qualitative analysis on the nurse notes among LEP participants that explicitly mentioned a language barrier. We leveraged a grounded theory approach to analyze our data. This consisted of a joint open coding session to develop our open codes, followed by an affinity diagramming session to group open codes by common themes to form our axial codes, then followed by a comparison against the TIPS workflow to form our selective codes, and then ground our working theories in the nurse's daily work and operation. We then conducted a chi-square analysis to compare the frequency of the qualitative themes between the LEP and EP participants. To do this, we applied a codebook developed by Nguyen et al., trained on the same nurse note data from TIPS, to systematically classify the content of the nurse notes. We mapped the qualitative themes to the codebook and then determined whether the themes were present in the nurse notes at scale. We calculated the chi-square statistic and p-value to determine whether there is a statistically significant difference between the observed and expected notes for LEP and EP participants. If the observed count was higher for LEP participants, we concluded that the qualitative theme was more prominent among this population. Now, moving on to the results, I'll first discuss the themes we found related to challenges in information gathering, which was our first research question. The first thing we found was the inability to establish contact with participants. Nurses expressed three major reasons for this, either having a wrong or invalid phone number in the participant's profile, participants being hard of hearing, or participants were unavailable to speak, in which case nurses would leave voicemails. The second theme we identified was a lack of available and effective translators. In nearly 20% of nurse notes, they indicated that an interpreter was requested to translate the conversation between the nurse and the participant. This does not include notes that documented a family or caregiver taking over the communication. We found several instances where translators were either unavailable, ad hoc, or ineffective. If translators were unavailable when requested, nurses could either leave the alert task as unaddressed in their portal. Some actually tried to use tools like Google Translate. However, this was not always successful. As you can see in the second quote on the left-hand side of the slide, they tried to use Google Translate in their conversation, but the client still wasn't really able to understand. And in the last scenario, nurses attempted to converse with the participant. In this case, they were typically characterizing the participants as speaking like little or some English. However, even in these conversations, participants would kind of sometimes only state that they felt like fine or okay, and there's no other real discussion about the participant's symptoms related to the alert that took place. And as a result, nurses didn't always get the contextual information that they were seeking. As you can see on the bottom quote on the left-hand side, the nurse wanted to follow up with a participant, but the participant, quote, couldn't explain it. Finally, even if a translator was available for conversation, we found that they were often ad hoc or not professionally trained. In these situations, participants would rely on somebody nearby, like one of their neighbors, who very kindly agreed to translate whenever they were available. Or they would try to work with the on-site interpreters at a local TIP site if they were there in person. However, nurses would complain that the interpreters on the TIP sites weren't actually fluent in both English and the participant's preferred language. For our second research question, we discovered nurses employed two common workarounds when they encountered these challenges. We found that participants who specified a caregiver to speak with nurses on their behalf were more likely to provide detailed context and information regarding participants' health status and concerns. For instance, in this note, while the nurse initially called to discuss a high blood pressure reading, a participant's daughter was able to then discuss other health concerns that the nurse could advise on, which was documented in the quote on the top. However, the notes also captured the toll that caregivers experienced while taking on these additional responsibilities. For example, in the quote on the bottom, you can see the participant's son was expressing frustration that it was difficult for him to balance the caregiving responsibilities with other life commitments. When nurses were unable to contact either the participant or caregiver, or if they couldn't get all the information from the phone call, they would often use review history as a supplemental information source. We saw that nurses would document trends or the most recent vital signs when they could not conduct the medical assessment as per their protocol. For our third research question, we observed statistically significant differences in the prevalence of these qualitative themes between LEP and EP participants. We observed frequency of differences between undocumented communication challenges. For example, we found that the wrong or invalid phone number theme occurred 2.5 times more often among LEP participants than expected. So we observed 48% of notes related to wrong or invalid numbers associated with LEP participant compared to the expected 19%. And this was a statistically significant finding. On the other hand, the theme unavailability to speak, which we approximated with the code leave message in that codebook, occurred statistically significantly less than expected among LEP participants, now 2.7 times less often than expected. So we only observed 7% of the notes for this theme were associated with LEP participants when we were expecting about 19%. This indicates that leaving a message is an underused method among LEP participants. Families and caregivers providing rich and contextual information was one of the workarounds that we had identified, and we mapped this to the discuss symptoms code in the code book. And this was occurring statistically significantly more often than expected, among LEP participants, about 1.5 times more often than expected. However, the other workaround of nurses supplementing information through offline vital sign review history, investigated using the content codes, review history, or within normal limit, both occurred significantly less often than expected. This implies that offline vital sign review history is an underutilized workaround among LEP participants. Our findings suggest several considerations for future design and research work. The first step to addressing challenges around language barriers would include understanding the needs, interests, and technology capabilities of embedding translation services. We should be mindful not to introduce high-cost, overly complex technical systems that would be challenging for LEP participants and their caregivers to adopt or are completely inaccessible. If participants are harder to reach by phone, CTPs can consider multimodal support by providing multiple diverse communication methods that incorporate audio and text-based messaging. Providing multiple modalities can help promote accessibility and improve digital inclusion, especially for those individuals who are hard of hearing, as we discovered. We could have followed the Design for All movement, where the goal is to design products that would be suitable for most potential users, that are easily adaptable, and built with standardized interfaces where specialized interfaces can be integrated as necessary. Finally, we can consider technologies that monitor participants' health to better contextualize vital sign readings and service that back to nurses as a way to support the offline supplemental review, which we found was underutilized. But there is, if further contextual information is needed, with the monitoring results, this information can be asynchronously exchanged between the nurses, participants, and caregivers. However, we must consider the participants' right to privacy. Future solutions should allow flexible user controls that allow for direct information sharing between older adults and their caregivers only when participants provide consent. I will briefly discuss the limitations and future work for our study. There may be selection bias present in our data, as participants who never got an alert response or may experience barriers accessing tips were excluded from our analysis. We had an imperfect mapping of our qualitative themes to the codebook used for our quantitative analysis, and we did not fully consider all external factors such as socioeconomic or policy factors or differences across tip sites that could contextualize or impact our findings. Future work should include follow-up studies with nurses and LEP participants to learn more about the challenges and workarounds from their perspectives and gather their perceptions on potential technology solutions. In conclusion, our study demonstrates how nurses gathered information with LEP participants and their caregivers. We identified disruptive factors that limit the TIPS nurses' ability to follow their alert response protocol to address LEP participants' alerts and the workarounds that they employed. We quantified at a larger scale, comparing how often these themes of disruption of information gathering and workarounds occurred among LEP versus EP participants within this TIPS site. And we discovered there may be an over-reliance on caregivers and the potential to scare other workarounds that nurses have already started to employ. And finally, we explored future design implications for addressing these challenges in other community telehealth programs, contributing to the continued efforts to improve healthcare delivery to this vulnerable and underserved population. Thank you so much for listening to our presentation, and please feel free to reach out with any questions. Thank you.